Welcome to part 4 of Therapy of Infectious and Parasitic Disease. This section of the presentation is going to review bacteriostatic inhibitors of protein synthesis. Here in the US, we have 7 tetracyclines that are available to us. And because they're broad spectrum antibiotics, they actually will work against a variety of gram-positive and gram-negative bacteria. And you can see on the slide the list of selective organisms that are sensitive to tetracyclines. Because tetracyclines are all pretty similar in their mechanism of action and their adverse side effect profile, we're going to just talk about them as a whole group, tetracyclines, instead of choosing a prototype. So first we'll talk about the mechanism of action. The tetracyclines suppress bacterial growth by inhibiting protein synthesis. These drugs are going to bind to the 30S ribosomal subunit, which is going to inhibit the binding of the transfer RNA to the messenger RNA ribosome complex. The addition of this amino acid to the growing peptide chain will then be prevented. At the concentrations that we need to achieve clinically, tetracyclines are bacteriostatic. In terms of selective toxicity, it's resulting from poor ability to cross the human cell membranes. And in order to influence protein synthesis, tetracyclines first have to gain access into the inside of the cell. But these drugs can't enter our cells like they enter bacteria. Our cells lack the transport system, so they cannot actively accumulate tetracyclines. So although tetracyclines are capable of inhibiting protein synthesis in our cells, their levels within host cells are so low that they're not really harmful. The therapeutic uses for tetracyclines are first to treat infectious disease. And you can see the sensitive organisms there. Disorders for which we use tetracyclines as first-line treatments are for rickets, like Rocky Mountain spotted fever, infectious disorders that are caused by chlamydia, like urethritis, cervicitis. We also use it for cholera, pneumonia that's caused specifically by Mycoplasma pneumoniae. We can use tetracyclines for Lyme disease, anthrax, and again, H. pylori. But we don't just use tetracyclines for infectious disease. We actually also use it for acne, and we will reserve the use of tetracyclines for severe acne vulgaris. And the way that it works is that it's actually going to suppress the growth and the metabolic activity of Propionibacterium acnes, which is the organism that's secreting the inflammatory chemicals. We use it for H. pylori, which is the bacterium that lives in the gut and is a major contributing factor to PUD or peptic ulcer disease. And we use tetracyclines in combination with flagyl and bismuth, which is the treatment of choice for getting rid of H. pylori. We will also use doxycycline and minocycline for periodontal disease. And doxy can be given orally or topically, and minocycline is only topically. With oral doxycycline, the benefit of this is that it's inhibiting collagenase, which is an enzyme that will destroy connective tissue in the gums. So we only use a small dose, and we are just using enough to harm the bacteria. So let's get into the pharmacokinetics now. So far, everything that we talked about, pretty similar across all 7 tetracyclines. But it's in the pharmacokinetics that things start to differ. Specifically, it's the difference in the half-life and the route of elimination across these tetracyclines. So it's important to look them up before prescribing and understanding which ones have a shorter or longer half-life. You also want to think about the degree to which food will decrease absorption. So some of the tetracyclines have a greater risk for doing so than others. And you'll see in the next few slides a chart that will show you what these are among the 7 tetracyclines. Now, tetracyclines are widely distributed to most tissues and body fluids, but the penetration to the cerebral spinal fluid, or CSF, is poor. The levels in CSF are too low to treat meningeal infections. So tetracyclines aren't used for this reason. Tetracyclines also cross the placenta and enter the fetal circulation. So important to understand that also. So what are the adverse effects? And like I said earlier, most of these adverse effects are the same among all tetracyclines. We'll go to the next slide to discover a little bit more about this. In the GI system, tetracyclines can irritate the GI tract. And so oral therapy is frequently associated with side effects like epigastric burning, cramps, nausea, vomiting, and diarrhea. We can actually reduce these GI symptoms, this irritation, by prescribing the medication to be given with meals. Now, even though food can decrease absorption, this can help with this side effect. The reactions can be reduced by giving tetracyclines with meals. Okay, in rare occasions, tetracycline can also, though, cause esophageal ulcerations. So you want to think about, how do we eliminate this risk? If we can prescribe this medication and tell our patient to avoid giving themselves the medication, or you need to avoid dosing the medication at bedtime. Diarrhea can also result from a superinfection of the bowel. And this is in addition to just having non-specific irritation in the first place. So it's important that you understand if the diarrhea that the patient is complaining about is really from an adverse reaction to the tetracycline, or if it's something else that's going on in their bowel. Okay, tetracyclines are not always good for your bones and your teeth. They bind to calciums in developing teeth, and it can actually result in yellow or brown discoloration. Additionally, hypoplasia of the enamel can happen as well. And this intensity of your tooth discoloration is related to the total cumulative dose. So if you are on tetracyclines for a very long time and maybe very large dosage, the staining is going to be darker. And if you're on repeated treatment of tetracyclines. If you give a tetracycline to a woman after the 4th month of gestation, it can cause staining of the deciduous teeth of the infant as well. Use during pregnancy isn't going to affect your permanent teeth. Discoloration of permanent teeth also happens when tetracyclines are given to patients between 4 months to 8 years old. And this is because this is the time when your enamel is being formed. And remember that it causes hypoplasia of the enamel. So please avoid ordering tetracyclines or prescribing tetracyclines to children that are under 8 years old. Of all the tetracyclines, in terms of discoloration of the teeth, doxycycline seems to be the safest. Tetracyclines that are taken by pregnant women can also suppress the growth of long bones in premature infants. But the effect is reversible when you discontinue the treatment. Okay, with a superinfection. Remember, superinfection is an overgrowth with drug-resistant microbes, and this occurs secondary to the suppression of drug-sensitive organisms. And because tetracyclines are broad spectrum, they actually can decrease the viability of a wide variety of microbes in your body. And so the risk for superinfection is greater with tetracyclines than let's say if you had used a narrow spectrum antibiotic. The super infection that can occur is usually in the bowel with staphylococci or C. diff, which is going to produce severe diarrhea and can sometimes pose to be life-threatening. The infection caused by C. diff is also known as antibiotic-associated pseudomembranous colitis. If this happens, you need to tell your patient to tell you, because if the diarrhea is significant enough that there's a possibility of bacterial superinfection, they need to be evaluated. And if they are diagnosed with superinfection, we have to discontinue the tetracycline immediately, and then they're going to be started on oral vancomycin or Flagyl, plus they need fluid and electrolyte replacement because of the diarrhea. Also, in addition to C. diff, the overgrowth of fungi usually is Candida albicans. This is occurring in the mouth, the pharynx, even the vagina and the bowel. What your patients will mainly complain of is itching and inflammation. They might have lesions in the anogenital area, and their tongue might appear to be black and furry because of the fungal infection. And if they are diagnosed with this type of superinfection, you again have to discontinue the tetracyclines. Tetracyclines can also cause hepatotoxicity, and specifically they can cause fatty infiltration of the liver. Patients will manifest with symptoms of lethargy and jaundice, and rarely would it progress to liver failure. But liver damage is most likely when tetracyclines are also given IV in very high doses, so greater than 2 grams a day. If you have a pregnant or postpartum woman that already has kidney disease, they're going to be at really high risk. In terms of renal toxicity, tetracyclines may exacerbate someone that already has renal impairment or pre-existing kidney disease. And because tetracycline are eliminated by the kidneys, these agents should not be given to patients that have a renal impairment. Now, let's circle back and talk about the drug and food interactions in a little bit more depth. Tetracyclines can form non-absorbable chelates with certain metal ions like calcium, iron, magnesium, aluminum, and zinc. And these substances can contain ions that include milk products, calcium supplements, iron supplements, magnesium containing laxatives, and most antacids. So, if a tetracycline is administered with these things that were just mentioned, the medication itself, the absorption of this medication is going to be decreased. So in order to minimize this interference, we would tell the patient to take their tetracycline at least an hour before or 2 hours after eating any of these chelating agents or chelating agents. Again, those are the milk products, calcium supplements, iron supplements, magnesium containing laxatives, and most antacids. Lastly, let's talk about the major precautions. There are 2 tetracyclines, tetracycline and demiclocycline. They are eliminated primarily in the urine, and they can accumulate to toxic levels in patients with kidney disease. So you wouldn't want to use demiclocycline and tetracycline with patients with kidney disease. They can also, again, as a reminder, cause discoloration of the deciduous and the permanent teeth. You don't want to give it to pregnant women or children under 8. You want to look out for superinfection of C. diff specifically, but also it could cause a fungal infection. And high dose IV usage is associated with severe liver damage. And in pregnant and postpartum women can lead to kidney disease. So you wouldn't want to give them tetracyclines. So all in all, tetracyclines have a pretty similar adverse effect profile, but there are two tetracyclines that are just a little bit different that we just discussed. And here are the tables that will help you to understand the major difference between this classification, which were the pharmacokinetic properties of the tetracyclines. So we're thinking about the half-life, the route of elimination, and the effects of food on absorption. Please look at this slide and examine it to see which tetracyclines are short-acting, immediate-acting, and long-acting, and which drugs have a large decrease effect from food absorption versus a small effect. Remember, we talked about doxycycline being of one of the least, and how they are eliminated by urine, through the GI tract, renal tract as well. We're going to move on to macrolides, which are also broad spectrum antibiotics. And macrolides are antibiotics that also inhibit bacterial protein synthesis. And they're called macrolides because they are big, macro. Erythromycin is the oldest, and we use it as a prototype. It's the oldest member of this macrolide family. But we also have newer macrolides like azithromycin and clarithromycin, which are derivatives of erythromycin. If a patient is allergic to penicillin, macrolides are a great choice. We can use them against most gram-positive and some of the gram-negative bacteria, and you can see on this table the routes of administration, the dosing intervals, and the dosages of azithromycin, which most of us remember it as Zithromax, clarithromycin, and erythromycin. Now we're going to talk about in the others class, and when I say others, other drugs that are bacteriostatic inhibitors of protein synthesis. One of these drugs is called clindamycin. And clindamycin can promote severe CDAD, which is a condition that can be fatal. And because of this, the indications of using clinda or clindamycin are very limited. Systemic use is only indicated for patients with very certain anaerobic infections that are located outside of the central nervous system. Now, clindamycins bind to the 50S subunit of the bacterial ribosomes, and they will inhibit protein synthesis this way. This site at which clindamycin binds overlaps the binding sites also for erythromycin. As a result, these agents may antagonize each other's effect. So this is important to understand as well. But really, there's no indication for concurrent use of clindamycin with any other type of antibiotic. In terms of its antimicrobial spectrum, clindamycin is active against most anaerobic bacteria, so the gram-positives and the gram-negatives, and also most gram-positive aerobes. Now, the gram-negative aerobes are generally going to be resistant to clindamycin. The therapeutic use. Because of its efficacy against gram-positive cocci, clindamycin has been used widely as an alternative to penicillin. But again, primarily only for anaerobic infections that are outside the CNS, because it does not cross the blood-brain barrier. And clindamycin is a drug of choice for certain things. For severe group A staphylococcal infection, for gas gangrene, and its ability to rapidly suppress the synthesis of bacterial toxins makes it a great drug for these situations. Again, for severe group A staphylococcal infections and gas gangrene. Similar to the other drugs we discussed, a major adverse effect is actually CDAD, which is Clostridium difficile associated diarrhea, or C. diff. And we also used to call this antibiotic associated pseudomembranous colitis. Well, CDAD is the most severe toxicity of clindamycin. And it causes a superinfection in the bowel with C. diff, which is that anaerobic gram-positive bacillus. And what most patients will experience if they have CDAD, or the C. diff associated diarrhea, is very profuse watery diarrhea, like 10 to 20 watery stools a day, accompanied with abdominal pain, fever, and additionally with leukocytosis. And the stools often will also contain blood and mucus. If your patient acquires CDAD from clindamycin, usually the symptoms are going to begin the first week of treatment, and they can last 4 to 6 weeks after you remove clindamycin from their treatment plan. If you don't do anything at all, or the patient fails to tell you about their profuse diarrhea, then the condition can actually be fatal. With parenteral and oral therapy, CDAD will occur, and because of the risk, patients have to be instructed to report significant diarrhea. So if someone has more than 5 watery stools a day, they need to tell you. Once you diagnose the superinfection, obviously you're going to discontinue clindamycin, and immediately you're going to give them oral antibiotic, a different oral antibiotic. Hopefully you remember that oral vancomycin or Flagyl are the drugs of choice for eliminating C. diff from the bowel. And usually within 3 to 5 days after starting vancomycin, you should be able to eradicate the C. diff from your patient. In addition to clindamycin, you can see on this chart other bacteriostatic inhibitors that are sometimes offered to our patients. You can look at their specific class and mechanism of action, their therapeutic use, the pharmacokinetics, adverse effects, and drug interactions. I did want to point out that on this chart, mupirocin or Bactroban is an antibiotic that does not have any other drug antibiotic. And we can also give this topically for someone that has impetigo that's caused by Staphylococcus or Streptococcus. We can also use it to eliminate nasal colonization for MRSA. But I just wanted to bring that up just because of these drugs, it does not have another drug interaction. And I want you to find the drug that actually is metabolized through the CYP3A4 complex. One other drug worth mentioning about that was, I believe, second on the last chart is linezolid. And it's also, the trade name is Zyvox. It's first in class of this type of antibiotic, and it's called an oxazolidine. And this drug is important because it works actively against multi-drug resistant gram-positive pathogens, including VRE, which is vancomycin resistant enterococci, and also works well with MRSA, methicillin resistant Staphylococcus aureus. And so for treatment of MRSA, this drug is at least as effective as vancomycin. But if you also have a co-infection of vancomycin resistant enterococci, then using Zyvox or linezolid is a good choice. But because we don't want to increase the risk of resistance, we only want to use this drug if we know that a patient has an infection caused by VRE or MRSA. But it has been approved for other uses, but we try to reserve it because we don't want to promote antibiotic resistance. In terms of its mechanism of action, it's a bacteriostatic inhibitor protein synthesis binding to the 23S portion of the 50S ribosomal subunit. And that is where it's blocking the formation of the complex initiation. So as a result, the cross resistance with other drugs is unlikely. And actually, in clinical trials, the development of resistance to this drug was rare and only occurred in association with prolonged treatment for VRE infections, or if someone had a prosthetic implant or an abscess that was not drained. The therapeutic uses, we talked about VRE and MRSA, but we can also, because it's been approved, use it for community-acquired pneumonia that is caused specifically by the S. pneumoniae strain. And these are penicillin-susceptible strains only. We can also use this drug for complicated skin infection and infections that are caused by skin sutures that were derived by Staph aureus or MRSA strains. Streptococcus pharyngeans, and Staphylococcus agalactiae. I do just want to stress one more time, though, even though these things have been approved, please reserve this drug for VRE and MRSA if you can. In terms of adverse effects, it's generally well tolerated, but the most common side effect is diarrhea, nausea, and headache. Now, interesting, the oral suspension contains phenylalanine, and so because of this, we can't give it to patients with phenylketonuria, and they are not able to metabolize this. Also, it can cause reversible myelosuppression, which will manifest itself as anemia, leukopenia, thrombocytopenia, and sometimes even pancytopenia. So, you might need to consider ordering a CBC to be done weekly while your patient is on this medication. If it worsens or if there's a new myelosuppression that develops, you have to discontinue the use of the drug. And rarely, prolonged therapy could be associated with neuropathy. And if you are needing to use this drug for more than 5 months, they may develop a reversible optic neuropathy and an irreversible peripheral neuropathy. In terms of drug interactions, they will actually weaken the inhibitor of the MAL classifications and pose a risk for hypertensive crisis. And when you combine these drugs together with SSRIs, they can also increase the risk for serotonin syndrome.